Imagine standing in an intensive care unit, right? And you're watching a nurse prepare to just remove a piece of plastic tubing from a patient's neck.
Right, which on the surface looks like the most benign task in the world.
Exactly. You'd think, you pull it out, apply some pressure, slap a dressing on it, and you're done.
But that is definitely not what happened.
No. Instead, the bed is abruptly flattened, the patient's head is tilted downward, the nurse leans in, instructing the patient to, take a deep breath, hold it, and bear down as if they're lifting something incredibly heavy.
Yeah, the tension in the room just spikes.
Because if the timing of this removal is off by
even a single second?
right, a sudden hiss of air could get sucked into the open vein, travel straight to the heart, and cause, immediate cardiovascular collapse.
It's a phenomenal contrast. I mean, we see these lines sitting quietly taped to a patient's chest or arm for weeks, just blending into the background of standard hospital equipment.
Yeah, completely invisible almost.
But the physical laws governing them are just incredibly unforgiving.
And that is exactly what we are focusing on today. Welcome to our deep dive into central venous catheters, which are universally known as central lines.
A very fitting name, as we'll get into.
For sure. So our mission for you today is to completely re-examine this vital access point. You might look at a central line and assume it's just, a heavier-duty version of a standard 5E.
Which is a super common misconception.
Totally. But today, we are breaking down the fascinating battlefield physiology of these lines, the hidden biological and honestly bureaucratic risks they carry, and the intense daily discipline required to keep patients safe.
Yeah, we have a really great stack of sources covering the core principles, the debates surrounding complication rates, and the meticulous care protocols required for these lifelines.
So to understand why a central line demands that level of respect, we first have to establish what makes it, central.
Right, and the defining feature has absolutely nothing to do with where the needle punctures the skin.
Okay, let's unpack this. Because framing the device entirely around its destination completely changes how we evaluate the risks.
Exactly. A catheter earns the classification strictly based on the final resting place of its tip. By definition, that tip must reside in one of the great vessels of the body.
Specifically, the lower third of the superior vena cava, right?
Yep, right at the cavolatral junction where it meets the right atrium of the heart.
So the destination dictates the fluid dynamics, which is kind of the entire point of the device.
Oh, absolutely. The superior vena cava is this massive conduit. Blood is rushing past that catheter tip at roughly 2 liters per minute.
2 liters a minute. That's just wild to picture.
It really is.
So if I can offer an analogy here to help visualize that flow rate, placing a standard peripheral IV into a small vein in your forearm and pushing highly concentrated medications through it. It's like dumping a bucket of harsh industrial chemicals into a tiny, slow-moving creek.
Right, the chemicals just linger there.
Exactly. It inevitably damages the banks of that creek. But a central line bypasses the creek entirely and drops that same payload directly into a roaring river.
That's a perfect way to look at it. The volume and the velocity of that flow instantly disperse whatever you're putting in. The sources actually highlight total parenteral nutrition, or TPN, as the classic example of this.
Right, IV nutrition.
Yeah. When a patient relies entirely on IV nutrition, the fluid is incredibly hypertonic. It's thick, heavily concentrated stuff.
And if you try to infuse that into a standard arm vein, the clinical guidelines cap the concentration at about 900 milliosmoles per liter, right?
Spot on. And the reason for that strict cap comes down to basic cellular osmosis.
Because if you put something that concentrated in a small vessel.
Right. The massive number of solute particles creates an osmotic gradient. It literally draws water out of the veins and endothelial cells just to balance the concentration.
Oh, wow. So it's basically dehydrating the vein from the inside out.
Precisely. Those cells shrink, which triggers this immediate inflammatory cascade, resulting in severe phlebitis.
And that inflammatory cascade is exactly what destroys the peripheral access, which forces the care team to constantly, hunt for new veins.
Yeah, it's a nightmare for everyone involved, but central lines bypass that limitation completely.
Because of that 2 liter a minute flow.
Exactly. You can safely run TPN at 1,800 to over 2,000 milliosmoles per liter through a central line.
Rather than double the peripheral limit.
Because it hits that roaring river, the hypertonic fluid is diluted into the systemic circulation instantaneously, long before that damaging local osmotic gradient can even form against the vessel wall.
That actually clears up a major misconception I hear from people. Folks who are somewhat familiar with the infection risks of central lines often wonder, Why don't teams just default to standard IVs to play it safe?
Right, they think, just use the smaller needle, it's safer.
Exactly. But it's not a simple hierarchy of safety, is it?
No, not at all. It's about matching the tool to the therapy. Delivering a harsh vesicant like highly concentrated potassium chloride or continuous vasopressors through a peripheral IV risks extravasation.
Which is when the drug leaks into the surrounding tissue, right?
Yes. And that can cause severe localized tissue necrosis. A central line neutralizes that specific devastating risk.
And this destination-based definition completely changes the calculus on things like PICC lines too, peripherally inserted central catheters.
Oh, absolutely. The entry point for PICC is in the arm, usually the basilic or cephalic vein in the bicep.
Which feels psychologically very similar to a standard IV.
It does, but the catheter itself is significantly longer. It's threaded all the way through the shoulder, the axillary and subclavian veins, until the tip reaches that exact same caboatrial junction near the heart.
So clinically, biologically, and from a risk surveillance standpoint, a PICC is a central line.
100%.
Which is wild. So threading a piece of plastic all the way into the central circulation to harness that massive blood flow is an incredibly effective concept.
Brilliant.
But successfully navigating a needle and a wire deep into the chest cavity, mere millimeters from the lung and major arteries, that seems terrifying. How did we even figure this out?
Well, the push to solve that anatomical puzzle actually originated under really desperate circumstances. The foundational technique goes back to a French surgeon named Robert Aubagnac in 1952.
Okay, 1952.
Yeah, and he was operating in battlefield conditions, attempting to rapidly resuscitate soldiers who were suffering from profound hemorrhagic shock.
And when a patient is in profound shock, their peripheral veins shut down completely, don't they?
Exactly. The body aggressively clamps down on the veins in the arms and legs to shunt whatever blood volume is left to the brain and vital organs.
So you physically cannot thread a standard IV into a fully collapsed arm vein.
You just can't. So Aubagnac leveraged a crucial piece of human anatomy to bypass this. The subclavian vein, which is positioned just beneath the collarbone.
The clavicle, right?
Right. It doesn't collapse. It remains open even in severe shock because the vessel wall is physically tethered to the underside of the clavicle and the surrounding dense tissue.
So it acts almost like a rigid tent, holding the vein open regardless of how low the patient's blood pressure drops.
That's exactly it. The access point is permanently available.
But, I mean, stabbing a hollow needle blindly into the chest of a bleeding trauma patient still sounds like a remarkably blunt instrument.
Oh, it was. But the refinement of that blunt instrument came just a year later, in 1953, from a Swedish radiologist named Sven Ivar Seldinger.
Ah, the Seldinger technique.
Yes, and it is arguably one of the most elegant mechanical solutions in modern medicine. Instead of trying to force a large, stiff catheter directly through the tissue and into the vein.
Which sounds awful.
Yeah, super traumatic. Instead, you puncture the vessel with a very small gauge hollow needle. Then you thread a soft, flexible guide wire through the needle and down into the vein.
Okay, so the wire is in.
Right. Then you remove the needle, leaving only the wire in place. And finally, you slide a dilator and the actual catheter over that wire, which guides it perfectly along the established path.
It's like threading a needle, but from the inside out. That transforms a high-risk puncture into a really controlled, scalable insertion.
And we still rely entirely on the Seldinger technique today.
But an emergency trauma line designed to pour in fluids for a few hours on a battlefield is fundamentally different from, say, a line placed in an oncology patient who needs aggressive chemotherapy for 6 months.
Totally different requirements. The leap to long-term central access didn't happen until the 1970s with John Broviac and later Robert Hickman.
Okay.
They were managing medically fragile patients, particularly those undergoing intensive bone marrow transplants. So they swapped out the stiff plastics for wider, softer silicone tubing that could live safely in the veins for months.
But the material alone wasn't the biggest breakthrough, was it?
No, their true innovation was this tiny little cuff made of Decrin, which is a synthetic polyester wrapped around the external portion of the catheter that sits cuddled under the skin.
I read about this in the sources. That Decrin cuff essentially tricks the body into accepting the foreign object.
Right. It creates a localized inflammatory response. The body's immune cells, like macrophages and fibroblasts, recognize the porous synthetic texture of the Decrin.
And then they just grow into it.
Pretty much. Over the course of a few weeks, those fibroblasts migrate into the cuff and lay down a dense collagen matrix.
So the tissue biologically integrates with the polyester.
Exactly. It locks the catheter in place and creates this impenetrable fibrotic barricade that physically stops skin bacteria from migrating down the outside of the tubing and into the bloodstream.
That is just brilliant.
Yeah.
But, given that we've been refining this tech and these anatomical approaches since the 50s and 70s, surely we figured out the absolute safest place on the body to put these things by now, right?
And you would think so.
Huh.
But the medical community is actually still heavily divided on the best approach because there is no universal safest site.
It's all about trade-offs, isn't it?
Strict geography of clinical trade-offs.
Ah.
We have really extensive data on this, most notably from the landmark 3 Sites trial, which was published in the New England Journal of Medicine in 2015.
Right. They looked at the 3 primary access points.
Yeah. The subclavian vein in the chest, the internal jugular in the neck, and the femoral vein in the groin.
Let's break down those trade-offs, starting with the Chestov-Baniak's original subclavian approach.
So the subclavian site boasts the absolute lowest rate of catheter-related bloodstream infections and symptomatic blood clots.
Because it sits on a nice, flat, clean portion of the chest.
Exactly. It's incredibly easy to maintain a sterile dressing there. But the trade-off is mechanical.
Because of the lungs.
Right. Because the vein rests intimately against the top of the lung, it carries the highest risk of insertion trauma. Specifically, there's a 1 to 2% risk of causing a pneumothorax collapsing the lung during the needle stick.
Which is a pretty terrifying complication. Conversely, the femoral vein in the groin removes the lung from the equation entirely, right?
It does. The femoral line is technically much easier to place, particularly during a chaotic code blue when the chest and neck are crowded with other providers.
And 0 risk of hitting a lung.
0. But its anatomical location makes maintaining strict hygiene exceedingly difficult. The groin is just not a clean area. So the femoral site carries a vastly higher incidence of severe bloodstream infections and deep vein thrombosis if the line stays in place for more than a really short emergency window.
So it requires a critical care team to actively weigh the immediate mechanical risk of insertion against the creeping cumulative risk of infection, all based on what they expect the patient's clinical course to be.
It's the daily balancing act, yeah.
Although it's worth noting that the mechanical insertion risks across the board absolutely plummeted in the early 2000s when the standard of care shifted.
Yes, you're referring to the widespread adoption of real-time 2D ultrasound.
Driven heavily by those 2002 NCLEX guidelines. Yeah, right.
Exactly. For decades, physicians relied on the blind landmark technique, feeling for the collarbone, finding the pulse in the neck, and just advancing the needle based on where the vein should be.
Which sounds so antiquated now.
It really does. Using ultrasound to actively visualize the needle tip entering the vein on a screen vastly reduced the incidence of accidental arterial punctures and failed attempts.
But even with perfect ultrasound placement, securing the access is just the beginning of the timeline. Because the moment that line is active, the clock starts ticking. The body now has a permanent highway from the outside world directly to the heart.
Which leads to the most persistent battle in critical care.
Right. The long-term maintenance of these lines revolves almost entirely around preventing CLABSI or central line-associated bloodstream infections.
CLABSIs represent a massive systemic threat in healthcare.
And this brings us to one of my favorite stories in medical safety. The Keystone ICU project, spearheaded by Dr. Peter Pronovost at Johns Hopkins, which was published back in 2006.
Such a game changer.
It really was, because he tackled these catastrophic infections not by engineering some fancy new antimicrobial polymer, but by introducing a rigid 5-item piece of paper, a checklist.
And the elegance of the intervention is in its simplicity.
Let's run through those 5 steps.
Sure. 1, strict hand hygiene. 2, maximum barrier precautions during insertion.
Meaning the doctor wears a sterile gown, mask, and cap, and the patient is covered entirely with the massive sterile drape, not just a tiny towel.
Right. 3, skin antisepsis with chlorhexidine instead of the old povidone iodine. 4, actively avoiding that femoral site in the groin for adult patients whenever possible.
Because of the infection risk we just talked about.
Exactly. And 5, a daily rigorous review of whether the line is actually still needed.
The results of standardizing those 5 steps were just staggering. The median rate of CLABSIs across the participating ICUs plummeted from 2.7 per 1,000 catheter days to 0.
Absolute 0.
This essentially free checklist decimated a leading cause of hospital-acquired morbidity. But the true genius of the Pronovost checklist wasn't just the physical steps. It was the cultural shift, right?
Definitely. The protocol explicitly empowered nurses to halt the procedure if a physician compromised the sterile field.
Anyone could speak up.
If we connect this to the bigger picture, the Keystone Project demonstrated that clinical safety is fundamentally an active, continuous system. It's not a set-it-and-forget-it thing.
And sadly, the COVID-19 pandemic revealed exactly how fragile those active systems are.
It was a stark natural experiment. When ICUs were overwhelmed, patient-to-nurse ratios exploded, and severe patients required continuous prone positioning lying on their stomachs. The daily, meticulous maintenance of those lines became nearly impossible.
And hospitals that had proudly maintained zero CLABSI rates for over a decade suddenly watched their infection numbers surge.
Because the safety net didn't fail due to bad science, it failed because the operational capacity to execute the checklist completely collapsed under the strain.
Which highlights a really significant friction point in clinical practice. When an infection happens, it's really easy to just blame the doctors or nurses, to assume someone must have skipped a step in the dressing change or contaminated a port.
And while breaks in techniques certainly do happen, blaming the staff ignores the fundamental biology of placing a synthetic object into the human bloodstream.
Because bacteria don't just float passively in the blood, do they?
No, especially ubiquitous skin flora like Staphylococcus epidermidis. When they encounter that plastic catheter, they adhere to the surface and begin secreting an extracellular polymeric substance.
It's like a dense, slimy matrix of sugars and proteins?
Yes, a biofilm.
A biofilm.
And this biofilm acts as an impenetrable biological shield. It firmly anchors the bacterial colony to the catheter wall.
And the matrix actually physically blocks the patient's white blood cells, right?
White blood cells and systemic IV antibiotics, they just can't penetrate it. Once a biofilm forms on a central line, you cannot simply push antibiotics through the tube to sterilize it. The infection risk compounds every single day that plastic remains in the vein, regardless of how flawlessly the nurses manage the external dressings.
That biological reality feeds directly into the really intense political and bureaucratic debates surrounding CLABSI reporting.
Oh, the surveillance gaming.
Yeah, because counting these infections isn't just an internal quality metric anymore.
No, in the United States, CLABSI rates dictate hospital reputation metrics and heavily impact financial reimbursement from organizations like Medicare.
Which creates a massive perverse incentive. The CDC's definitions for what technically counts as a CLABSI are incredibly complex, right?
Very complex. They rely heavily on ruling out other potential sources of the bacteria in the blood. And that complexity creates administrative loopholes.
So if a patient with a central line spikes a fever and their blood cultures come back positive,
hospital infection control teams are highly incentivized to meticulously comb through that patient's chart to find an alternative primary source.
so they'll look for anything else to blame.
Exactly. If they can clinically justify that the bacteria actually originated from, say, a suspected urinary tract infection or a developing pneumonia, the event gets reclassified. It's no longer a CLABSI.
Wow. So the hospital's dashboard stays green, the financial penalties are avoided, but the fundamental safety of the patient in the bed hasn't improved whatsoever.
It is the ultimate manifestation of Goodhart's law. When a measure becomes a target, it ceases to be a good measure.
That is wild.
Yeah.
But okay, let's assume the clinical team navigates all of this successfully. The patient's condition improves, they satisfy step 5 of the Pronovost checklist, and the doctor says, great, we can pull the central line.
The prevailing assumption for most people is that removing the device eliminates the danger. You pull the tube out, the infection risk drops to 0, and the patient is safe.
But here's where it gets really interesting. It goes back to the very first thing we talked about today. The physical act of removing a central line is treated as a high-stakes, code blue emergency drill for nursing students.
Because of that destination near the right atrium.
Right. Explain why taking a simple tube out creates such a terrifying physical dynamic.
It all comes down to atmospheric physics and intrathoracic pressure. The central venous system, especially the superior vena cava near the heart, operates under very low pressure. During inspiration, when a patient breathes in, as the diaphragm drops and the chest cavity expands, the pressure inside the chest actually becomes negative relative to the outside atmosphere in the room.
It essentially creates a vacuum effect inside the vein.
Exactly. So if a nurse pulls a large bore central line out of the jugular vein in the neck, and the hole connecting the skin to the vein remains open for even a fraction of a second,
The pressure differential just takes over.
the vein does not simply bleed outward like you'd expect. Instead, atmospheric pressure forcefully pushes ambient air down the tract and sucks it directly into the central circulation.
An air embolism.
A sudden, massive bolus of air travels instantly into the right ventricle of the heart. The mechanical churning of the heart whips that air and blood into this frothy airlock.
And that blocks the blood flow.
It completely obstructs the pulmonary outflow tract. The heart continues to pump frantically, but no blood can reach the lungs. It induces immediate, often fatal, cardiovascular collapse.
Which perfectly explains the highly choreographed procedure we talked about at the start of this deep dive. When the nurse lowers the bed, they aren't just positioning the patient, they are actively battling a pressure gradient.
Right, the entire removal protocol is designed to artificially manipulate that pressure.
Yeah.
Placing the patient in the Trendelenburg position, which is tilted head down, uses gravity to increase venous pressure at the top of the chest.
And then having them bear down.
That's the Valsalva maneuver. Bearing down forces a massive spike in positive intrathoracic pressure. This guarantees that when the catheter slides out, the pressure inside the vein is higher than the pressure in the room, forcing blood out rather than letting air in.
And then they immediately slap on an airtight occlusive dressing to physically seal the hole.
Exactly. It's not just the insertion procedure in reverse. It's a completely different physiological battle.
It is just a remarkable sequence of events.
Yeah.
When you step back and look at the full life cycle of a central venous catheter, the takeaways are just profound.
They really are.
We define these lines not by how they enter the body, but by their destination in the high-flow central circulation.
Yeah.
A destination that allows for aggressive therapy, like TPN, but brings unique, lethal risks.
Right.
Placing them requires a calculated trade-off between mechanical lung punctures and cumulative infection risk. Maintaining them relies heavily on the rigid discipline of a daily checklist to combat the inevitable biology of biofilms. And finally, just discontinuing them requires a flawless manipulation of atmospheric physics to prevent a catastrophic air embolism.
And, this raises an important question, I think, about how we conceptualize safety protocols in high-risk environments.
Absolutely.
The history of the central line demonstrates that medical safety is not a permanent achievement you can just secure with better technology or a newer plastic. It is a fragile, active practice that must be relentlessly executed and defended every single day.
It absolutely does. And it leaves me with a final thought for you to explore on your own. We discussed how Dr. Pronevost's remarkably simple 5-point piece of paper eradicated central line infections in ICUs across the country.
Yeah.
It succeeded because it fundamentally democratized safety. It gave the frontline nurse the institutional authority to halt a highly trained physician if a basic standard was compromised.
Which is huge.
It really makes you look at the broader world and wonder, what other incredibly complex, high-stakes environments, whether in commercial aviation, corporate boardrooms, or even the daily operations of your own workplace, are currently vulnerable to catastrophic preventable failures simply because they lack a basic checklist that empowers every single person in the room to speak up?
It's a great question.
Think about that the next time you see a seemingly benign piece of plastic tubing taped to a patient's arm. It's never just plumbing. Thanks for joining us on this deep dive. We will catch you next time.